You've almost certainly heard the name Parkinson's disease. But what's really going on inside the brain and body? In this explainer, we're going to get right into it. What the disease is, how it actually shows up, and the incredibly complex ways we try to manage it. All right, let's dive in.
So here's what we're going to cover. First, we'll get a handle on the disease itself. Then, we'll look at how to recognize the key signs. After that, we're exploring the whole philosophy behind treatment, digging into the specific medications, and finally, checking out some of the most advanced options out there today.
So, what exactly is Parkinson's? Well, before we even touch the science, let's just talk about the sheer scale of it. How many people we're really talking about?
Okay, let's start with a number that just kind of stops you in your tracks. 1 million. That's how many people right here in the United States are living with Parkinson's. It's a huge number, and it really underscores why it's so critical for us to understand this condition.
So, who does this affect? Well, it usually shows up sometime between the ages of 40 and 70, but the most common time for it to start is in a person's 50s. It is slightly more common in men. But the big takeaway here is this: Parkinson's is everywhere. It's found in every country, across all ethnic groups, and in every socioeconomic class. It really doesn't discriminate.
Okay, so we know who it affects, but how do you actually recognize it? Well, it all comes down to a really specific set of signs, and they're broken down into two main groups. The symptoms get grouped into two buckets. You've got the 4 cardinal signs. These are the big ones, the major physical signs like tremors and stiffness that are really core to the diagnosis. But then there's this whole other range of secondary signs, things like cognitive changes, trouble with speech, or even something as subtle as your handwriting suddenly getting way smaller. They actually have a name for that. It's called micrographia.
Let's zoom in on one of those key terms: akinesia or hypokinesia. Now, this isn't just about being a little slow. Akinesia means you literally can't get a movement started, and hypokinesia is when your movements become really small and weak. This particular symptom is one of the absolute hallmarks of Parkinson's. Understanding the symptoms is one thing, but what do we do about them? That's the other half of the story. So, what's the core strategy here? What's the game plan for managing Parkinson's? Now, this next point, this is probably the single most important thing to grasp about treating Parkinson's right now. See, at this moment, there is no treatment that can stop or even slow down the progression of the disease. Think about that. What it means is we can't stop the disease from getting worse, and that one hard fact changes everything. The entire goal of treatment today is to manage the symptoms and give people the best quality of life possible. So this leads to a really tough choice, right at the beginning, for both doctors and patients. Do you hit it hard with a powerful drug like levodopa for the best possible symptom control right now? Or do you play the long game? Maybe use a different class of drugs, called dopamine agonists, to try and delay some of the long-term side effects. It's this constant balancing act between what's best for today and what might be best for the future.
All right, let's open up that toolbox then. What are the specific medications doctors are using to manage these symptoms day in and day out? And this really shows you how targeted the treatments can be. We have meds that can help with tremors, with rigidity, and with bradykinesia. That's the slowness of movement we talked about. But then, look at that last row. Gait disturbances. For the problems with walking and balance, which can be one of the most devastating parts of the disease, there's just nothing. No effective medication at this time. That is a huge hole in our treatment options. So how does the workhorse medication, carbidopa/levodopa, actually do its thing? Honestly, it's a really clever two-part system. Think of carbidopa as the bodyguard. Its only job is to protect levodopa on the journey through the body, making sure it doesn't turn into dopamine too early. This lets more levodopa safely cross the blood-brain barrier. Once it's inside the brain, then it converts to the dopamine the brain so desperately needs to control symptoms. Pretty smart, right? But levodopa isn't a perfect solution, especially over the long haul. You run into these challenges. Wearing off is pretty straightforward. It's when you start to feel your symptoms coming back before it's time for your next pill. But the on-off phenomenon, man, that's something else entirely. Imagine you're feeling good, your meds are working, you're on, and then, out of absolutely nowhere, bam, the off state hits and your symptoms come roaring back for no predictable reason. It's a huge challenge to live with. So, to help out levodopa, doctors have a bunch of other tools that all attack the dopamine problem from different angles. You've got dopamine agonists. They're basically dopamine imposters that trick the brain's receptors.
Then there are MAO-B inhibitors, which act like shields protecting the dopamine that's already in the brain from getting broken down. And COMT inhibitors are like extenders. They help the levodopa you take last longer. Each one is a different approach to the same core issue. And this is definitely not a one-size-fits-all situation. Just look at the ranges for these dopamine agonists. What works for one person could be totally wrong for someone else, even with the exact same drug. Finding that perfect sweet spot where you get the most benefit with the fewest side effects is a really delicate and super personal process for every single patient.
All right, so what happens when the standard medications just aren't cutting it anymore, or when totally different problems start to pop up? Well, that brings us to our last section, the really advanced stuff and special treatments.
For surgery, the go-to option these days is something called deep brain stimulation, or DBS. The easiest way to think about it is like a pacemaker, but for your brain. It doesn't cure anything, but it sends these tiny electrical pulses to very specific areas to block the faulty brain signals that cause the motor symptoms like tremors and stiffness.
But even with this surgery, it's not simple. There are choices. Surgeons can target one of two different spots in the brain. Going for the globus pallidum is often seen as the safer bet, maybe with fewer cognitive side effects. Targeting the subthalamic nucleus, on the other hand, can be more effective, but the risks might be a bit higher. It's another one of those incredibly complex decisions that comes down to the individual patient and their surgical team.
And finally, this is so important to remember. The shaking, the stiffness, those visible symptoms are often just the tip of the iceberg. Underneath the surface, you can have all these other struggles: psychosis, cognitive problems, serious depression, and major sleep disorders. Every one of these non-motor symptoms is its own battle and needs its own specific treatment plan.
So, think about it. Everything we've talked about, every single treatment, is about managing the symptoms. It's about patching the leaks. But not a single one of them actually stops the disease itself. And that leads to the biggest, most important question of all. How do we get from just patching the leaks to actually stopping the flood? What's it going to take to finally find a treatment that doesn't just manage Parkinson's, but actually stops it in its tracks?